Hello everyone and welcome to the discussion on pediatric mental health and cognitive perceptual diagnoses in children. So let's start our discussion off by first looking at attention deficit hyperactivity disorder. So as many of you probably already know, ADHD or ADD is the most commonly diagnosed pediatric mental health disorder that providers will see in primary care. Also important for you to understand is that you certainly are capable and it is within your realm of practice to diagnose, manage, and treat attention deficit hyperactivity disorder in primary care. And unfortunately, in many instances, these children are not getting the care they need in the primary setting because the education, knowledge deficit, and barriers to getting good treatment for these children really starts at the primary care provider's office. So it's important for you, if you will be seeing across the lifespan as an FNP, to know what your limits, your boundaries, and your abilities are with regarding to treating mental health disorders. So essentially, ADHD is something that affects various functions cognitively, behaviorally, and also physically in children. Self-regulation is action an individual takes that results in change in that behavior to modify the likelihood of a future consequence or attainment of a goal. So what we're really looking at with children who have ADHD is treating and managing the symptoms of what this diagnosis can do for them. So it requires intact executive functions, in which 6 have been identified as being present in children, and that's listed here for you. Activation, which is organizing, prioritizing, and getting started. Focus, sustaining and shifting attention to a task. Effort, which is regulating awareness, sustaining effort, and processing speed. Emotion, which is managing frustration and modulating emotions. Memory, or utilizing working memory and accessing recall. And then action, which is monitoring self-regulating action. So it's important also for you to know as a provider that ADHD affects more than just the child. It affects relationships in the family. It also affects the child's ability to make good friends. Peer relationships and social relationships are difficult for children who have attention deficit hyperactivity disorder because their minds are running at a little bit of a faster pace than children who do not have this diagnosis. Some of the things that you might see parents complain about is difficulty not only in the classroom, but also difficulty with siblings, difficulty at home, difficulty while in public, etc. If you have a child who presents to you that only has difficulty at home, but the child's teacher or other important adults in the child's life don't seem to have the same kind of concerns that the parents or caregivers or adult that's caring for the child primary and full-time is having, then that may be something that you would really have to carefully look at as far as diagnosis goes, because it may be a child who doesn't in fact have attention deficit, but maybe having some behavioral management issues or in fact some family dynamic problems. So the 3 main types of attention deficit hyperactivity disorder, and these are things that you will see as diagnosis or billing codes. So you want to make sure that you are appropriately assessing which one of these subtypes that children are. So you have ADHD, which is combined type, and that means that they have significant symptoms from both the inattention and hyperactivity or impulsivity. All right, ADHD predominantly inattentive, which that really essentially means exactly what it states, in which the child has more symptoms of inattentiveness than they do of the hyperactivity. And then also ADHD, which is predominantly hyperactive and impulsive. And in these cases, children have the diagnosis with more symptoms of hyperactivity and impulsiveness. All right. So the other important thing for you to understand for a diagnosis of ADHD are what are the criteria, okay? So there are essential features, there are things that must be or almost always are present, but it's important for you to know what the criteria for diagnosis is and to be sure that you are screening for and diagnosing it appropriately with valid and reliable instruments. Otherwise, the child may in fact have another disorder altogether, or may just be having coping skill difficulty, or another diagnosis such as trauma. There's a large percentage of children who present with a history of major trauma or PTSD, and they're diagnosed with ADHD incorrectly because the symptoms are very similar. So, essential features: inattentive and hyperactivity or impulsiveness, of course, before the age of 12. That's something that's really important for your diagnosis. If it's occurring in adolescence after 12 years and there's never been concerns or problems before that, then you need to be looking elsewhere for a diagnosis. Next, several inattentive or hyperactivity impulsive symptoms are in more than one setting, and or two settings, sorry. I did just discuss that a little bit, but you're looking for it to be present in home, school, work, with friends and relatives, and in other activities. This really is not something that's just going to be at school or just going to be at home. Also, there needs to be clear evidence that the symptoms interfere or reduce the quality of life in that child, okay? How are they functioning at school, at home, in their relationships, or at work for your older adolescents? Next, the symptoms don't happen only during the course of schizophrenia or another psychotic disorder. So basically, if you have a child who is got another major psychiatric diagnosis and they've got these symptoms in the presence of another major psychiatric disorder, then that's probably not what is going on as the diagnosis. It could just be concomitant or a co-issue with the other diagnoses. Next, the symptoms are not better explained by another mental disorder. This one's really important for you to think about. As I was just saying, there are disorders, there are conditions, there are honestly just common normal developmental issues that happen in childhood that could lead to some of these criteria, some of these features or clinical manifestations. So it's important for you as the provider in primary care to do a really good thorough assessment in addition to your screening tool, because if you miss that diagnosis and you inappropriately prescribe a stimulant, you're probably not going to see much help with that child, because a child who has ADHD will usually benefit from the medication that you prescribe, but a child who does not may get no effect at all except this unfortunate side effects of the medication that you've prescribed. All right, so let's talk a little bit about the inattentiveness, okay? So they're going to be a kid who does not pay close attention. They may make a lot of careless mistakes, especially in schoolwork, especially in their jobs if they're in early adolescence. They have difficulty sustaining attention even in tasks that are playful. So it doesn't mean that they won't enjoy watching TV or enjoy playing video games or enjoy playing their toys, but these are kids that are going to probably jump from one activity to the next quickly. So 5 or 10 minutes in each toy activity, and want to spend not so much time focusing on that play or that activity primarily. Now, that doesn't mean that a child with ADHD may not sit down and play their favorite video game for an hour. They definitely might do that, okay? And to tell you the truth, many children who have ADHD will stay so hyper-focused on something that is stimulating their brain very actively, such as a video game that keeps them busy, and it doesn't mean that they do not have ADHD. So you want to make sure you're looking carefully at all of the criteria. These kids don't seem to listen. Okay, now that you might be saying, oh my gosh, that's all kids. Yes, that's certainly true. Children normally and developmentally will have some selective hearing and some selective listening. But these kids will seem not to listen right when they are spoken to directly. They're repeatedly not listening. They're repeatedly not following simple commands. And they seem to be distracted even when caregivers or someone who is an adult or authority figure is talking to them. They will often not follow through on instructions, okay? They have difficulty organizing tasks and activities. They avoid things they don't like a passion, okay? They will be very reluctant to engage in tasks that they know will make them sustain mental effort for a long time. That's a lot of the reason why these kids will struggle while in school for long periods of tests or long periods of seminars or presentations by teachers, because it's something that they struggle with to sit and spend a long time trying to focus on something. They're unable to do it. And it can cause also a lot of self-esteem issues, essentially, for these younger children. All right, so these kids also might lose things a lot. You'll find caregivers coming in and telling you, oh my gosh, I have bought this child 10 notebooks. I buy him a pack of pencils every week because he never seems to find it. He's losing his books constantly. We can't let him rent things from the library because we've paid for so many books that he's lost. Or he's unable to keep his keys to open the door after school. He never submits his homework. Or he may have lost his glasses, or if it's an older adolescent, a telephone several times. Those are things for you to keep in mind because children who have ADHD or ADD will lose things a lot. And it's not necessarily because they are too careless. It's more often than not because they're not paying attention and they lack that major organization that other children who do not have this diagnosis do have. All right, so other things are that they're just easily distracted and they're easily forgetful, even with daily activities that they do all the time. So the reason this is so frustrating for caregivers is because really a lot of parents will come in and tell you, oh my gosh, she's just not doing what I ask her to on purpose. She'll purposely not do her chores even though she knows she has to. That's really not. Doing chores, running errands, returning calls, paying bills, keeping appointments, or submitting assignments, even the ones that they've already done, are common mishaps that you'll see in a child who has ADHD or ADD. So just remember that in making your diagnosis. All right, so lastly, the hyperactivity or impulsivity traits. Okay, you want to see at least 6 or more of the symptoms of hyperactivity and impulsivity for children up to age 16, or 5 in kids who are 17 and older. You want to make sure that these symptoms are present for at least the past 6 months, okay, because if these things are only been going on the last, 2 or 3 weeks, you may want to consider asking about life events. Is there something traumatic going on for the child? Are they failing a class? Have they recently moved out of state or in state? Is the child having to switch schools? Are they struggling with bullying? There are many things that can lead to behavioral issues in children. So again, making the appropriate diagnosis based on the criteria is essential. Okay, so hyperactivity and impulsivity. These kids are going to fidget a lot, okay? They may tap their hands, tap their feet, squirm a lot, and they're not going to be a kid who can sit still very easily. They will often leave their seat in situations such as being in school, being in a restaurant, being in church, being in other social gatherings, and it's difficult for the caregivers to deal with this, especially when the child is not listening to repeated commands and repeated times that the parent has asked them not to. Often runs about, climbs in areas that's not appropriate, okay? Unable to play or engage in leisure activities quietly. These kids don't like to sit down and read a book. These are kids who like to be active, loud, moving many body parts. Their gross motor skills are on fire, okay? They move around quite a bit. Often on the go, acting as if they're driven by a motor. In fact, that's one of the questions on the screening tool that you will see for the Vanderbilt assessment. They may talk a lot. In fact, it's difficult when adults or other children are around these kids for someone to get a word in edgewise. So you can imagine why these kids have difficulty developing peer relationships, because they're the only ones doing the talking, and they're also very active in moving from one sentence or situation or idea to the next. So conceptually, it's difficult for other kids to make these relationships work. All right, so they also will often blurt out, answer before a question has even been completed. They have difficulty waiting their turn, and they often interrupt others. So some of the ADHD treatments that you are going to be considering, the main things that you will be looking at for first-line treatment is going to be stimulants. I am not going to go over every stimulant therapy for ADHD because there's quite a bit. In fact, there's some really, really old therapies that are still used, like traditional, just plain methylphenidate. And then there are the treatment therapies that are even more advanced and more new, things like Vyvanse, Focalin, um, Adderall. Those things are a little bit more newer and more traditional to be used now because they are long acting. But the most important thing you should know about medication management for ADHD is that the first line treatment is a stimulant. There are certainly non-stimulant treatments available for ADHD, but they are not first line. Several years ago, the American Heart Association came out with a position statement that children with ADHD needed to have an EKG done prior to having stimulant medication prescribed. That is not adequate or appropriate, and the AAP actually came out and did a position statement to challenge that. And we do not in primary care or in other care institutions order an EKG just because you are going to prescribe a child a stimulant. There's nothing to suggest that that would be cost effective or appropriate, regardless of the stimulant having some mild risk for arrhythmias or cardiac arrest. So one of the common drugs you'll see that's non-stimulant is Strattera. And there certainly are kids that you may prescribe a non-stimulant medication to. Kids who can't have stimulants, kids who you've tried stimulants on first and it doesn't work, or even kids who have ADHD but caregivers refuse to let you put them on a stimulant because of something they've read and they're concerned about. So you have different ways that you can approach the diagnosis and the treatment regimen, but remember that a stimulant therapy is the first line. The other thing to consider is non-stimulant medications actually have a much higher adverse effect list than stimulants. So, and Strattera is one of those that has quite a long side effect or adverse effect list. So just make sure that you're following an appropriate algorithm, using evidence-based practice, and you are focusing on which type of ADHD it is, because that also can matter with the management that you're choosing. So the next thing, let's talk just a little bit about sensory processing disorder. This is a cognitive perceptual disorder that is a lot more common in children nowadays because we know more about it. So over the last 10 to 20 years, there's been a lot more evidence to suggest that this diagnosis is real, it does exist, and with all of the new education and literature and knowledge that we have about the diagnosis, it's been easier for us to diagnose it and to help treat it. So children who have sensory processing disorder, it's something that can be very difficult for them, just like ADHD, to develop relationships, but really their brain is on sensory overload. Okay, so when you think about what all of the 5 senses are, those things are going to be super heightened in a child with sensory processing disorder. So taste, touch, smell, light, noise, all of those things are going to be difficult for a child who has sensory processing disorder to manage. And so treating sensory processing disorder is something that is where you're treating the child, but you're also helping to treat that sensory overload. So let's go over just a little bit of these red flags you may see in children with sensory processing issues. Most of the time, this diagnosis is not made until after toddlerhood. However, looking back, many caregivers will tell you, oh my gosh, I did see those symptoms even that young. But they won't necessarily be complaining about them when they come in to see you, because they may just toss them off as being normal toddler or infant behavior. So infants and toddlers who struggle with sensory processing issues may have trouble eating or sleeping. They refuse to go to anybody but a specific person that they've developed a really strong relationship with. Irritable when being dressed, uncomfortable in their clothes. Okay, so that would be the sense of touch, certainly. They don't like to play with very many toys because that sense of touch is very heightened, that sensitivity. So they may pick just a few toys that they like to play with, as opposed to some children who love a range of toys. They may not want to cuddle. They may arch or back away when someone tries to hold them because the sense of touch is a little bit too much for them. They have difficulty calming themselves, or they have a floppy or stiff body, and sometimes they even have a motor delay. Now, for preschoolers and grade schoolers, the symptoms become a little bit more apparent for the caregiver, and these are the things that you'll see them coming in with. So, very sensitive to touch, noise, smell, and other people. Okay, these kids may grab their ears if they hear even what you think is just the slightest noise. Difficulty making friends, obviously, because when you think about a typical preschooler or grade schooler, they're touching all over each other. They're playing house, they're out there playing tag, and they're running into things on the playground, and in the classroom they may be sharing crayons and pencils and drawing on each other's things. A child who has sensory processing disorder will really find that difficult to do, and so they won't engage in those other touches and loud noises that a child their age may engage in, and so it's difficult for them to make those friends. Difficulty dressing, eating, sleeping, and toilet training. In constant motion in everyone else's face and in their space. So that may sound like it's similar to ADHD. The difference is when they are in everybody else's face and space, they are able, when discussed with the caregiver and when they are pointed this out, they are able to pay attention and come out of that situation, as opposed to a child who has ADHD who's really not able to come out of that very easily. Temper tantrums. So kids all have temper tantrums, but children who have sensory processing disorder will have frequent temper tantrums, longer temper tantrums, and it will often be associated with some form of a sensory. So again, something that may have to do with light, something that may have to do with touch, something that may have to do with a smell or a taste or a noise. So the temper tantrum isn't really necessarily in this child going to be about not getting the slushie that they wanted at the grocery store. It may more than likely be about something like they do not want to wear the shoes that the parents have picked them out because they don't like the way they feel on their feet, or they do not want to wear the clothes that the parents have picked out because they want to wear something short-sleeved when it's 22 degrees out. So the temper tantrums really relate to the senses itself. For grade schoolers, similar to those of preschoolers, but the other things you might see is that these kids are easily overwhelmed, especially in school. So difficulty with handwriting or motor activities, again, difficulty making friends. So I'm sure you're noticing a pattern here, all the way from toddlerhood to grade schoolers, and it's also in adolescence. These kids have difficulty making friends. So you're going to want to make sure that you're talking about social relationship with caregivers and making sure that they get the support they need so that they can make those important friendships in school. Every kid needs friends to feel important and to have high self-esteem. So make sure that you're taking note of that and when you're diagnosing and managing these kids. All right. And so moving on to adolescents and adults, overly sensitive to touch, noise, smells, similar as the ones above. In the adolescent age and adulthood, you're going to start to see a severe self-esteem issues, afraid of failing at new tasks, and that's related to low self-esteem. Okay, these kids or these adolescents and adults may seem more lethargic and slow, or they could be impulsive and distractible. They could be one spectrum to the next, which makes it difficult, I understand, because, well, that may sound like depression when you're looking at lethargic and slow, or that may sound like ADHD when you're looking at impulsivity and distractibility. But remember, when you're making a diagnosis, you look at all of the criteria that must be present in order to make that diagnosis, and you must be using a valid and reliable tool for the diagnoses such as depression and the ADHD. So, oh, hang on, there's one thing I wanted to tell you here. If you want to, while you are in primary care, if you have a patient that you are suspicious of having SPD or sensory processing disorder, there is a very complete SPD checklist and sensory integration observation guide that can be used, and it's found at this website right here, the spdfoundation.net. Okay. And anyone that you suspect may have a more severe form of sensory processing disorder does need to be assessed and screened. All right, so the management of SPD or sensory processing disorder is going to depend on how severe the sensory issues are. Okay, so in most cases, you can really essentially work with the caregivers and send that child to an occupational therapist, because an occupational therapist that has training in sensory integration issues can help the child manage how to balance all of the problems and all of the sensitivities they have to the sensory issues. A referral to developmental specialist or behavioral specialist can certainly be helpful if the child is having social issues in addition to the sensory issues, which is very common. So you may find that you are referring the child to occupational therapy, but also referring the child to a developmental behavioral specialist. And then, of course, you want to make sure that you're monitoring for effectiveness in the treatment that they're getting, the occupational therapy and the behavioral or developmental therapy. It is not very common for children with SPD to require major pharmacological management. So it's not going to be common that you see a children who only has sensory processing disorder on lots of psychotropic medications or anti-anything with regard to SSRIs, SNRIs, or other psychiatric medications. So let's move on to ASD, or Autism Spectrum Disorder. This is another diagnosis that is really, in the last 10 to 20 years, come into more knowledge. So it looks like, when you look at the diagnosis of ASD over the past 50 years, it looks like we really have been diagnosing it so much in the past 10 years. But the truth is, we really just know more about it now. It's not that it's any more apparent. It's really not that we are seeing anything that is causing autism, such as vaccines. Okay? Vaccines do not cause autism. It's really just that we have got more evidence on how to diagnose this properly, and so we are managing our diagnosis and our recognition of this disorder a lot better over the past 10 to 20 years. So autism spectrum disorder is essentially just that. It's a spectrum, okay? So if you look here, it's a spectrum of severe pervasive issues, okay, to a high-functioning autism. Now, the diagnosis has actually been changed in the DSM-5. We no longer use the terminology such as Asperger's or other diagnoses that are individualized. It's simply autism spectrum disorder, and they are either high-functioning, severe autism, or somewhere in the middle. But essentially, the diagnosis is one, and they have separate levels, okay? So level 3 would be somebody that would be requiring substantial support. So we're having severe deficits in verbal and nonverbal social communication skills. Level 2 would be requiring substantial support. So you would notice marked deficits in the verbal and nonverbal communication skills, social impairments, and apparent even with supports in place. And then level 1, requiring support. So without support in place, deficits in social communication cause notable impairments. So you essentially have your level 1 as being the least severe up to level 3 being most severe. All right. So diagnostic criteria for autistic disorders are also quite specific. The time that you are going to first start to screen for or assess for concerns with autism is really going to be in toddlerhood. Okay, so between usually around 15 to 24 months is when you're going to see your first MCHAT score. You may give it at 18 months. It really kind of depends on where you're at in practice, but most of the time it's 18 and 24 months. And if you're seeing any concerns on that modified MCHAT, or essentially that is a tool for diagnosing or assessing for autism, you are going to make sure that you act quickly. So, because children who have autism really need resources very young. Not getting resources as soon as you notice symptoms or the possibility of a diagnosis of autism is going to hinder that child from getting everything they need and growing and also developing really effectively. So most of the time, the caregivers will report concerns to you. Okay, so they may say things like, she's just not as lovey as my daughter was when she was born, or he struggles so much with looking at me, or he doesn't seem like he's listening, or sometimes it seems like he doesn't know how to pay attention, or he can't hear me, or sometimes he plays so much with himself, but he does not ever integrate with other kids. He doesn't want to play with other children, he just wants to play with himself. Those symptoms can be as mild as that to as severe as no talking skills. Okay, so no speech whatsoever. The only communication the child has is screaming or head banging or really, really serious meltdown and behaviors, but those things are typically noticed pretty early. So, clinical findings when you've got children with autism spectrum disorder, this, again, is not diagnosed in as young as infancy, but looking back, when you do diagnose it in toddlerhood or a little bit later than toddlerhood, which is the typical age that it's diagnosed, parents will see, and even sometimes providers will see, oh yes, this infant definitely did have some of those symptoms, okay? So an infant may be passive or non-engaging, quiet, floppy, even colicky, poor eye contact, attention issues, or attachment problems with caregivers. So the toddler stage is the one that you're probably going to see the most common with issues presenting, because again, this is where we screen for it. Okay, so as a provider in primary care, this is where you would be screening for autism, but also where the behaviors become even more apparent because they are supposed to be really social butterflies at this age, and so when dad or mom takes the kid out for a play date and it's really noticeable the lack of those social skills, language delays, behavior problems, especially expressive language issues, all of those things become apparent to the caregiver, and also other parents may point them out to those caregivers. All right, preschoolers, language delays, of course, meaningful speech, decreased gestures, or gaze disturbances. Socially, preschool and school-age children certainly struggle, and just like children with sensory processing disorder, and I would argue that it's a little bit more severe in autism spectrum disorder, these kids struggle to make friends. They really struggle to keep healthy peer relationships because a child without autism spectrum disorder doesn't know how to understand that lack of socialism, or not socialism, sorry, but social interaction. They don't understand how to be friends with someone who does not want to engage with them, even if the child with autism really does want to. They don't understand why the child or peer isn't looking at them. Okay, so all of these things make it difficult for a child without autism to connect, engage, and develop a healthy peer relationship with a child who does have autism. And then children who are adolescents, you will likely be diagnosing autism before this age, but this is really new in the past, again, 10 to 20 years. Sometimes, if you take a look at early literature, children with or adolescents with autism, or even adults with autism, were just looked at as weird, or they were looked at as having some form of a mental retardation or a mental disorder. And we know very well that these kids a lot of times will excel in certain areas of their visual motor and problem solving, math skills, etc. So it has nothing to do with an intellectual disability in most cases, unless the disorder is severely pervasive. But in most children who have a mild form of autism spectrum disorder, they're quite intelligent. It's more of a problem with social skills. All right, so management of autism. A lot of times in primary care, we think of psychiatric disorders, or we think of mental health or cognitive spectrum disorders, or cognitive perceptual disorders, as something that we cannot manage and we cannot handle. That is so far from the truth. In fact, the evidence is so clear that the best place to start the management is in primary care. So it is up to you as future providers to be very careful in how you manage all of your patients with mental health and cognitive perceptual disorders. So in the case of a child who has autism, your treatment will really depend on how severe the level of function impairment is. So, going back to the level 1, 2, 3, the 1 was the lowest level of problem, up to 3, which is the highest level of social problem. So you want to make sure the first and foremost part of the plan of care with a child who has autism or suspected of having autism is going to be behavioral or mental health treatment. So this is the most essential aspect of their care, and they must be referred to someone who can manage this, at least in part. Now, one of the biggest problems is usually that you're going to find in the area of your practice, who do I send this child to? There are no experts in autism. There are no experts in the behavioral health issues that I need to refer for. That happens. I will not lie to you, and I will tell you that happens. So the best thing for you to do in that instance is to do your best to continue to search outside of the area for someone who can see them, and then in the time being, manage as much as you can manage in your level of education and knowledge prior to making that referral, even again if the referral is outside of your area. And you'll find that most caregivers are pretty accepting if they think that it will help their child to travel to go see a specialist, because a lot of times these specialists only need to be seen, 3 to 4 times a year if they're managing medications, or if they're getting therapy. It's obviously a little bit more frequent, but a therapist or a counselor is a lot easier to find than a developmental specialist. All right, so in the education system, you want to make sure that if you know a child has autism, or you are helping a child plan for care in their autism, that the teachers are involved, the administrators are involved. They have good plans. IEP plans are something that caregivers must know about, okay? And we learned about that in the first couple modules, with the difference between an IEP and a 504, and what these children can qualify for based on other medical conditions or learning disabilities. Medications. A lot of children who have autism actually do not require the use of pharmacological treatment, but some children who struggle with aspects of their autism, such as depression or anxiety, which is pretty common in autism, or mild forms of social disorder or attachment disorder, so they don't want to leave unless they're with mom or with dad or with their one sister or brother. Those kinds of things do sometimes get medicated, and you will see help in that symptom from the medications, but it's not too common that these kids have to be medicated. Diet or nutrition. The one important thing I wanted you to know about diet and nutrition is there's just not one diet that has any strong evidence to suggest that it's best for autism. You probably will hear parents come in and tell you, oh, I've read about a gluten-free diet being effective, or I've read about a diet free of red dye being super effective, or I'm going to put him on a diabetic diet because I've heard of no sugar being something that is related to diagnosis of autism, and if I give him no sugar, then he'll behave better. Or I've read that if I take out all of the corn and wheat in my child's diet, that he'll behave better. You are going to hear so much, and the best response to that is first to listen, okay, because you want to hear, these caregivers are stressed. They are scared, they are fearful, they want to do whatever they can to help their kids. So what you want to do is not endorse any particular diet, but as long as it's healthy and it's not something that will harm the kid, a gluten-free diet's not going to harm the kid. You can certainly tell the caregivers they can try something if it is not harmful. Just know all of the diets that they may present to you, and then do a follow-up. Okay, so if the parent comes to you and says, I want to do a no sugar diet because I've heard this will help his autism, and you say, okay, well, we can explore that together, and you can be honest and say, now, I do want you to know there's no evidence that suggests a low sugar diet will help with autism, or no strong evidence at that, but we can try it, and I'll see you back in 2 weeks, and you can tell me if you noticed a difference. If that child came back in 2 weeks and the parent says, well, I really feel like the behavior is better, we're having less sugar, then what are you going to do? You're going to just let the parent go with it. You're not going to tell them not to give the diet that they've tried that they feel is helpful. You're just going to provide them the evidence and do frequent follow-ups. Okay? All right. So similar to the diet and nutrition, complementary and alternative therapies such as essential oils, certain herbal remedies, or treatments over the counter, there is no strong evidence to support that they would help significantly with the diagnosis of autism. So your role is going to be to know what those complementary and alternative therapies are, and you will learn more about that in your final module of this class. But your role is to know more about those therapies and to be able to tell caregivers when they shouldn't be given, when they should be given, and to just be supportive if they're coming to you with a plan they think might be beneficial to try. All right, and lastly, very important, kids who have autism, there's lots of family coping issues going on. When a person who has a child diagnosed with autism is first told their kid has autism, it's kind of like, wow, I expected to have a child who is normal, to be developing just like every other child, to want to hug and love all over me, to want to play a staring contest with me. It's a lot to deal with. It is a significantly debilitating disease for a child, but it is also very hard for families to manage. The rate of divorce is also very high among caregivers who have children with autism. So please remember how important family counseling and support is. All right, so moving right along, generalized anxiety disorder. So anxiety disorder is actually something that is not diagnosed frequently enough in children. And a lot of times it will be diagnosed incorrectly, instead as depression or even as ADHD. So it's important that you are using the appropriate scales. Now, I did post quite a bit of the mental health disorder valid and reliable scales for you in the module, so make sure that you review those. But one of the most common ones is the SCARED scale. Okay, major symptoms of generalized anxiety disorder is really just going to be uncommon worry. So worrying constantly. Okay, so this isn't a child who, worries about a test the next week because they have failed a couple tests and that's it. This is the child who would worry about the population level in another state they're not living in and be concerned about the overpopulation level. Okay, so when you think about the level of anxiety in these kids, it's not going to be something that's pretty minor or typical. It's going to be something that you're going to go, okay, that's pretty severe worry. Or they may constantly be concerned about test grades, constantly concerned about the cleanliness in a bathroom, and how they feel like they're going to get sick every time they go in. Okay, or over concern about their performance. Okay, so maybe they played sports or they play a musical instrument and they're constantly obsessing and worrying about how well they're doing and how much they're going to please others and please themselves. They may have unexplained physical symptoms as well. Okay, so fatigue or abdominal pain. That's something that we see pretty common in kids who have anxiety. The unusual need for reassurance. So constantly asking whoever is around them, did I do okay? Did I this? Did I do that? What do you think about this? Just constantly needing that affirmation and that reassurance. And the other thing is you may see a comorbidity with other anxieties or mood disorders, of course. So what is the treatment for anxiety? The best thing for me to tell you about the treatment for children who have anxiety is cognitive behavioral therapy. Now, the problem is that how many of us know a specialist who does cognitive behavioral therapy in children? It's not easy to come by, okay? Many counselors, licensed clinical specialists, or therapists are not trained to do cognitive behavioral therapy. I'm not even trained to do cognitive behavioral therapy. It's a very specific psychological treatment, but it works really well. Okay, let me tell you why it works so well. When children have anxiety, one of the biggest things, and this is also goes for adults, but when they have anxiety, one of the biggest things is their thought pattern. Okay, so what cognitive behavioral therapy does is it changes that thought pattern. So let's just say, for instance, a child with anxiety is thinking, I'm never good enough. I'm not going to be good enough. I'm not going to be able to play this soccer game today because I don't think I'm going to score the amount of goals that I want to. So that's what a child who has significant anxiety might be thinking. But if we can try to change that thought pattern into a more positive thought, then the behaviors that come from the feelings will be changed as well. So the goal for cognitive behavioral therapy is, instead of the child thinking, I'm not able to play in this soccer game because I am not good enough, the thought might be, I might not make all the goals I want to, but I'm still going to get to participate and I'm still going to have fun and I think I'm going to do my best. So those are two completely different thoughts with the same exact scenario of going into that soccer game for that child. But the difference will be that they feel different about themselves because it's a more positive thought process, and then their behaviors will be different because they're thinking more positively. So change the way they think, which changes the way they feel, which also will help to change behavior. That's really essentially the goal of cognitive behavioral therapy. And cognitive behavioral therapy is an excellent form of treatment for all kinds of psychological disorders, but for anxiety, it's really the gold standard for kids who do not have a severe debilitating disease. All right, so the other thing that's important to remember is some children who have anxiety will certainly need medications. It is not something that you want to say absolutely no to, okay, because treating anxiety can be really scary. Before a lot of our newer age treatments in medications, all there was Ativan and Valium and Xanax, and that's scary. We don't give those kinds of medications to kids unless it's an extreme circumstance, and we certainly don't give those kinds of medications long term if we can help it. So the treatments that are more appropriate for kids who have anxiety is going to be things like your SSRIs, so your fluoxetine, your Prozac, your fluvoxamine, and then also in some instances possibly SNRIs like Zoloft. And then Buspar is another medication, or Buspirone is another medication that we've seen some success for in children. It's a mild form of a medication that is very helpful to decrease some of those scary thoughts and negative and worry, concern type of thoughts. All right, so moving right along, I wanted to talk just a little bit about obsessive compulsive disorder. This disease is not very common in children, but you will see it, and a lot of times you'll see it starting out as young as preschool and school age. Okay, so there's a really great little reference in your Burns book for quick screening questions for OCD, and it's just these 6 questions right here. Okay, and if obviously you can't ask these specific questions to the child, you may want to just ask the caregiver. But the first one is, do you wash yourself or clean more than most people? Do you feel the need to check or double check things often? Do you have thoughts that bother you that you would like to get rid of but you can't? Do you find yourself spending a lot of time doing things like brushing their teeth, getting dressed, washing themselves, locking doors, etc.? Does it bother you when things are not lined up or not in order? Or do these problems bother you? So basically, this last question is, do having all of the rest of these problems bother you in addition to having these problems? So just like we talked about before, the best treatment for obsessive compulsive disorder is really cognitive behavioral therapy. So in the same instance that these kids with generalized anxiety disorder need to change their thought patterns, so do kids with OCD. Because what you want to make sure that you are teaching them is that the reality is their hands do not need to be washed 37 times in order for them to be clean. But you can't try to convince a kid who has OCD of that. It's not something you're going to be able to look at them and say, but your hands are already clean. They will not think their hands are clean. So what they need is that kind of cognitive behavioral therapy that changes their own thought pattern to say, okay, my hands have been washed once, they are clean, it is okay for me to step away and not wash them again. So another thing for you to know that's very important is children who have severe forms of obsessive compulsive disorder do often require medication therapy. Okay, SSRIs are the most common, and this is something you can manage in primary care, but it certainly would be helpful for you to manage it in conjunction with a specialist that can do the CBT, or certainly a specialist who could at least provide them a form of counseling or therapy with their family. All right, next, trauma and PTSD. So I was talking a little bit earlier when we discussed the symptoms of ADHD. It is common, okay, for children who come in with signs or symptoms of ADHD to actually just have a form of trauma, whether that be acute or chronic or something that's long time in their past. Okay, so if it's long time in their past or if it's acute, it wouldn't necessarily make a huge difference in their trauma symptomology, but it's important for you to know, is it still ongoing? You know, is that trauma still happening, or is it something that happened in the past that they've been taken out of, but they're still actually suffering from? So the common symptoms that you're going to see, and I'm not going to really go over infancy and preschool age, but the common symptoms you'll see in older kids, school age and adolescents, are nightmares, developmental regression, repetitive themes in play, social withdrawal. Okay, they may act out, have problems with having extreme fear, panic attack, and also concomitant depression, anger, or rage. Those things are essential. So just because somebody comes in with a diagnosis of depression, anxiety, or rage, there may be something associated with that. Okay, they may have trauma that has led to that, which is the reason why they're anxious, or the reason why they are sad or having major depressed mood. So it's important for you as the caregiver to focus on the history and get a really good history from the caregivers and the child when you are diagnosing this. Referral to a pediatric mental health specialist is crucial. Okay, so cognitive behavioral therapy and trauma therapy are first line. There are specific things that specialists and you in primary care can do to help children with trauma. Okay, I mean, I've learned about very simple tasks, such as telling the child to come in and see you, and the next time they see you to bring a little box. Okay, a box with a top and something that they can open and they close. Or what I've done is I've actually just kept like $10 store boxes in my office. So if I have a kid who I know has been exposed or had significant trauma, I may do this little activity with them. And you take that box and you hand it to the child and you say, if they're old enough to write, you can do this in them writing things down. Or they can just pick it up out of the air and it's not really actually there, but they can put it in the box. This has happened and this has happened, and these are the things that I'm putting in this box that I want to put away. And I don't want to bother me anymore, and I don't want to hurt me. Doesn't mean they didn't happen. Okay, that's why you keep the box. But what it means is it doesn't have to bother you every single day. And you can educate and discuss with the caregiver and the child the importance of knowing that this is not something that has to affect daily life. All right, so as far as medication therapy goes, I don't find that medication treatment is needed a whole lot for kids who have trauma and PTSD, but sometimes, okay? But the most important thing for kids who have trauma is truly therapy. Trauma therapy and mental health specialist referral is the best thing for them, because they need to be able to work through that trauma and work through what has happened to them. And there's a lot of really good treatment regimens out there for trauma that are relatively new but have really strong evidence to support them. So one of those is EMDR, and I'm not a specialist in EMDR, but we do have some at UNCW, so I would recommend that if you are interested in referring to someone who could provide EMDR, that you look up that information to learn just a little bit more about it. All right, so moving right along. Social aggression, oppositional defiant disorder, and conduct disorder. So these are all a form of social aggression disorders, but I put them on the same page because it's very easy to get these conditions confused. So I put them here kind of side by side so that you could really kind of hone in on what the differences between them are. And a lot of the time the treatment is really essentially the same, but the diagnoses are quite different. So, when you have a child who has social aggression, that's a pattern of social behavior with the intent to harm others. That sounds really bad, but it doesn't necessarily mean that they want to, be homicidal or suicidal. It really just means that it could be virtual harm or social bullying. It could be physical violence, etc. And it could be covert or overt, gossiping or socializing, ostracizing. The key for social aggression is it's not quite as severe as these other two over here, but it's a way for you as a provider, if you're starting to hear some of these things from caregivers, well, they never listen, or they do this, or she's kind of a bully at school. It's a time for you to be thinking, okay, well, we're probably at risk for developing one of these others. It could be a precursor. So supportive therapy, counseling for children and caregivers, positive parenting strategies. If a pattern of social behavior is evident, then psychiatric referral is critical, okay? Because you want to make sure you catch it before it gets any worse. So oppositional defiant disorder and conduct disorder are the two that are a lot easier to confuse, okay? The main difference between conduct disorder and oppositional defiant disorder, a conduct disorder, in this instance, the child is really impinging or affecting the basic rights of others, or major age appropriate societal norms and rules are violated. Okay, so when you have a kid who's got oppositional defiant disorders, there's certainly a pattern of negative, hostile, and defiant behavior. Okay, it's certainly excessive in comparison to other children at that age. They may defy or refuse. They may be super argumentative, angry, and resentful. Lots of temper losses, lots of vindictive behaviors, lots of blaming for others and deliberately doing things to annoy kids or other adults. The difference between this and a child with conduct disorder. So a child with conduct disorder, they may have aggressive behavior that threatens or results in physical harm to people or animals. Non-aggressive behavior that causes property damage, like lying or stealing, or serious violation of rules or laws. So let me give you an example. Okay, so Todd has oppositional defiant disorder. He is constantly getting into fights at school. He is always arguing with his parents. He may throw things at home, break things, and he is got lots of problems blaming his siblings for all of the things that he does wrong. And the parents are really struggling with managing his behavior. Okay, so Todd has ODD. Sarah has conduct disorder. Not only is she have problems with major behavior issues, okay, but she also likes to, on occasion, go and break into her school at night, cause property damage in her chemistry class, think that it's funny, post about it on her social media account, and then when she gets in trouble, her parents take her car away. Well, as a result of her parents taking her car away, she gets very upset. She takes the keys, she backs out of the driveway, and then rams the car through the front window of the house, and then hands the keys to her parents and says, "Don't ever try to take my car away from me again." I am actually telling you a story of a patient that I came in contact with 10 or 12 years ago. So this is a true story. So I'm trying to show you the differences between oppositional defiant disorder and conduct disorder is that the violation of human rights and societal norm is very serious over here on the conduct disorder side, whereas the oppositional defiant disorder, you don't see that. All right. So another pretty common diagnosis that you will see in the pediatric population for primary care is depression. And I want to say on this very first slide about depression that a very big pet peeve of mine in primary care is that we think sometimes as non-psychiatrists or non-psychologists or non-psychiatric mental health nurse practitioners that we are not able to treat depression. And I am here to tell you that is 100% wrong. It's inaccurate. As a family nurse practitioner with appropriate training and appropriate education, you are more than capable and responsible for diagnosing and managing depression. Now, you are not always going to be able to do that alone, okay? You may need a specialist. You are going to need someone to help you with therapy, or you're going to need someone who possibly is a psychiatrist to deal with your serious patient cases where there's several comorbidities. You're going to need to work closely with the specialist. Possibly a cardiac disorder may also exist in this child who has depression, so you're going to consult with the cardiologist to make sure that these certain medications are safe for them, etc. What I'm trying to tell you is, please do not diagnose depression or notice depression and pass the buck. Do not diagnose it and say, well, we're going to refer you to someone who can manage this with your medication if they really need it. Okay, I see that all too often in primary care, and it is just such a shame, because essentially I have followed up on kids who 5 months prior were told to go see somebody for their depression and had been sitting for 5 months in horrible, horrible anguish, debilitating mental, emotional, and even physical pain from their depression. Their caregivers, in just distress and distraught and not knowing where to go. but they weren't able to find somebody to help treat them with medication. So they're coming back in primary care to see me, even though I saw that their depression could have been managed initially. So please do your job and be the best practitioner you can be and treat a child's depression or anybody's depression if you can. Get the education you need here in your schooling, and also continue to read evidence-based practice and consult with your supervising or collaborative physicians or your more experienced nurse practitioners and physician's assistants with you to do what's best for that patient. Okay, so I'm sorry, I did my little rant, but I want to make sure everyone in my class knows how essential it is that kids be treated for depression too, and they deserve to be treated. So the three main kinds of depression that you're going to see in children are one of these three: either a major depressive disorder, a dysthymic disorder, or adjustment disorder with depressive mood. So this one over here, adjustment disorder with depressive mood, you can kind of assume to be just the least severe. So these kids may have experienced something traumatic. Okay, so maybe their mother died, or their favorite aunt has moved away, or something that has caused them to be severely sad. Okay, it's typically occurs within a few months or, after a major life stressor. But it usually will be less severe. It will resolve on its own, and it's mild, and typically is quite brief. Next is dysthymic disorder. Okay, so dysthymic disorder is characterized by depressed mood or irritable mood for the majority of days for the past 2 years. That is less intense, but more chronic than major depressive episodes. All right, so here we have something that's kind of short-lived, short-lasting, and mild. Over here we have something kind of medium, moderate, longer existing, and not very severe, not as severe as major depressive, but it's there for a longer period of time. So these kids are dealing with a dysthymic disorder for a while. Major depressive disorder is diminished interest and pleasure in almost all of usual activities, or both, for a period of at least 2 weeks. Okay, now these things can be diagnosed and assessed with the use of valid and reliable instruments to measure depression, but also a good thorough history, a good physical exam, all right, and talking to caregivers and talking to the kid. Here's the other thing for you to remember. Depression, while it is a psychiatric disorder, can be caused by other physiological things. So if you have a child who comes in otherwise completely normal, no apparent problems, no life event, nothing that seems, wow, this might have brought this depression on, and all of a sudden they're coming in with depressed mood or major depression, you are going to want to do some lab work. Okay, so some of the things you might consider doing are thyroid panels, okay, a TSH, maybe a free T4. Another diagnosis that can lead to depression is a vitamin D deficiency or other minerals and vitamin deficiencies. So think outside the box, and certainly remember that depression can be caused by physiological problems. And I don't have time to go into every physiological problem that causes depression, but the major ones that you can see causing depression would be vitamin D deficiency and also thyroid disorder. So it's important for you to remember that those could be things that you would want to consider ordering in a patient that comes in to see you with a newly diagnosed depressed mood. All right, so the following symptoms of depression are common. All right, so they may be sad, down, angry or irritable, and bored. Males tend to exhibit a lot more irritability and social withdrawal than females. In fact, that may be the only symptom caregivers are reporting. They are so angry and irritable all the time, and they never want to hang out with our family anymore. That's a big red flag for you if you're seeing a young adolescent or school-age male that has that symptomology for depression. So you would want to make sure that you are considering that. Loss of interest in pleasures, change in appetite. They may have weight loss or weight gain. So don't think that they're only going to be losing weight. Don't think they're only going to be gaining weight. Insomnia or hypersomnia. Depression in adults is a little different than depression in kids for the sleep. So most cases of severe depression in adults leads to early waking. So you more often than not will see adults who are waking up very early in the morning if they have severe depression, whereas a child or adolescent with depression may actually be sleeping too much. So not wanting to wake up or get up for school, sleeping as soon as they get home from school, or sleeping from as soon as they get home from school, waking up to eat a small something and then going right back to bed until the next day. That's severe or hyperinsomnia, and it's not something that's typical. Now, on the other hand, all adolescents sleep a lot. So if you've got a parent coming in and saying, oh my gosh, she sleeps all the time, or he never wants to be awake, that's not too untypical, but do a good sleep history. A lot of teens also will like to sleep in the afternoon when they get home from school, but boy, they want to be up until like 1 or 2 in the morning. And that's why they can't get up in the next morning, and that's why they sleep after school. So it's different than them sleeping 18 hours a day. Okay, so low energy and fatigue, difficulty concentrating, okay? Not the same type of difficulty concentrating that you would see with ADHD. It's an inability to make a decision type of a concentrating problem. Feelings of worthlessness or inappropriate or excessive guilt. Okay, even guilt over themselves. I don't like how I look. I am too fat, or I am too skinny, or I'm not talented enough, or I'm never going to be like you, Mom. You have so much education and I have none. Or I'm never going to be like Dad. He can build anything he wants with his hands and I don't have any talent. Those kinds of things. Reoccurrent thoughts of death or suicidal ideation is going to be the most severe concern that you would worry about as a provider. And luckily, a lot of our really good assessments of depression scales will have that question on there. Some teenagers may not even tell you that's really going on, so it's your job to make sure you ask in a creative and constructive way if you really truly feel, or the caregiver feels like they may have suicidal ideation about that situation. All right, so a diagnosis of major depressive disorder is made, as we discussed, if there's been lots of depressed mood for at least 2 weeks, loss of interest, and at least 4 additional symptoms of depression. So this recent life events and losses, okay, it's important for you to look at the following here. Family history of depression, that is a big one. Depression is genetic. We already know that. There's lots of research and evidence to suggest that. If a mother or a father has depression, there is an increased risk for a child to have depression. So always ask about it. And you want to make sure you're asking in a very non-threatening way. So instead of saying, so do you have depression, or does your husband or does your boyfriend have depression? That might lead a caregiver not to want to answer you. Instead, say something like, depression tends to be really familial. We see it sometimes in mothers and daughters, or sons and fathers, or vice versa. Do either you or the child's father have a history of depression? Very gently, okay? Gently break it so that the caregiver feels safe to tell you what's going on with their own mental health or their previous mental health, so that it's in a non-threatening environment. And know that the only reason you want to know that is because you want to take the best care of their kid. All right, next, family dysfunction, changes in the school performance, risk-taking behaviors, and that includes sexual activity and substance abuse, deteriorating relationships with family, and changes in peer relations, especially social withdrawal, as we discussed up here with young males who tend to have that a lot. All right, so it's important also for you to know that even young people have thoughts about killing themselves. It is so sad for me to tell you this, but unfortunately a very recent study has just come out that over the last year, the incidences of young people, including school age and adolescents, going to the emergency room or to their primary care office with complaints of suicidality or thoughts of wanting to hurt themselves has increased a lot. It's in fact, I think, more than doubled. So it does exist. And if we ignore the earlier signs of depression without giving kids the help that they really need, then this depression can become worse. And it can lead to thoughts of, I'm better off dead. Who really would care if I'm not here anyway? Or the pain is just too much. For someone who's never had depression, or somebody who is living with somebody with depression, or someone who even is a provider of somebody with depression, it's not so easy for us to understand what that experience is like. Okay, but I will tell you that the way that most people describe it is so debilitating, not just mentally, but physically also. So these kids really need help. They need you to advocate for them if they've got a diagnosis of depression. And if they are thinking about hurting themselves, then you must act immediately. So changes in their behavior, changes in their mood, changes in their thinking, and major life changes. These are all warning signs of suicide. I won't go over every one of them right here, but you can certainly review these, and it's something for you to know exists, and hopefully we can, catch these issues early so that it does not lead to thoughts of wanting to hurt themselves. All right. So another thing that I wanted to make sure I shared with you is just, this is in your Burns text, and it is just essentially some age-appropriate and age-approved scales for measuring depression. One of the best that I have found, also quite easy for children to complete and also just quick, is the PHQ-9, and then also the PHQ-9 modified for teens. So the most important question I want to go over on the PHQ-9, though, it's essential for that question number 9. They could answer every question on the entire PHQ-9 as normal, okay? So they don't have any problems with anything on that entire questionnaire. But when they get to question number 9, it basically asks about whether or not they have thoughts of being better off dead or not being alive. They may answer that they think about that all the time. And if they do, even though their score would not necessarily be driving for major, minor, or moderate depression, that is an automatic major issue, and you must call attention to that. So I always caution caregivers, providers, on letting nurses or medical assistants do that scoring without clearing it with the provider reviewing the entire survey. I do all my own surveys like that, because if the nurse or the medical assistant were to hand you the scale and say, oh, they only scored a 3, they're good to go, and you may think, oh, okay, well, that's no problem. But if the 3 happened to be the question that they think about suicide, and that child ended up hurting themselves, obviously the child has already hurt themselves, and that's the biggest concern, but it's also major risk for you with your license. So always make sure that you're using a valid, reliable scale, okay, such as the ones listed here, but also that you are doing your own assessment, review, and scoring of these sheets. All right, so lastly, the depression management algorithm. The depression management algorithm is a really good tool for you to use in primary care. So with there's going to be 3 really good middle areas here. So if they meet criteria for mild to moderate depression, you're going to, cognitive behavioral therapy is another excellent form of treatment for depression. Or meets criteria for moderate to severe depression, immediate referral for psychiatry. And if they are harming themselves, harming others, or they're in the middle of a psychotic or manic attack, then they certainly need inpatient hospitalization. But if they don't, this is another good one. If they don't meet diagnostic criteria necessarily for depression with the scales that are valid and reliable that you've done, but you still have concerns that the child is, got a depressed mood, then educate. Okay, you want to educate the parent, educate the child. Do not just look at the parent and give all of the education. Talk to that kid, okay, because you need to know, they need to know they're being heard. Motivational interviewing, problem solving, nutrition, regular exercise. Guys, I cannot begin to explain the power that exercise has for depression, okay? Exercise is a natural serotonin booster. It releases endorphins in everyone who does it. So for those kids who don't necessarily meet diagnosis criteria, give them lots of good education, motivation, and also recommend enhanced problem-solving skills, improved nutrition, and exercise. So going back to the kids who have mild to moderate and moderate to severe depression. Okay, these kids with moderate to severe depression that need hospitalization, you obviously will not be treating inpatient. That would require a referral, but you may be seeing them for follow-up, okay? It's going to be the ones that are like mild to moderate that you'll be managing in primary care. So along with cognitive behavioral therapy, the most common treatment that we would see for young people is SSRIs, okay? And so that's going to be like your fluoxetine and the SSRI management, although it is kind of scary because there's an FDA warning about a black black box warning regarding suicidality increase in teens and in young people, or actually younger than, I believe it's 26. It's scary to prescribe that, I understand, but it is the most supportive with evidence treatment for depression in children is the SSRI. So you can feel encouraged that if a child truly has mild to moderate depression, needs medication management, that it is okay to start them on a selective serotonin reuptake inhibitor. All right. So that is really all that I had to share with you regarding mental illness and cognitive perceptual disorders in children. I look forward to the next education session, and please do not hesitate to reach out to me for any questions, concerns, or clarification.